for echocardiographic imaging of prosthetic heart valves in, I thought it was 15 minutes, so I just misread the time. So I may speak a little slower than I normally do, which will be a nice change. Nothing to declare with reference to this talk. All of the talk is going to center around two documents. One is our older document on evaluation of prosthetic valves by the American Society of Echo, and then the newer document from our European colleagues, again, recommendations for imaging prosthetic heart valves. But both documents are fairly clear that what's very important for the basic echo evaluation is the date of the valve implant, the type and size of the prosthetic valve, height, weight, and body surface area of the patient, symptoms and related clinical findings, and then blood pressure and heart rate. So again, getting to the point that one of the more important things that we can understand about that prosthesis is whether or not it's appropriately sized for the patient's body size, and whether or not the gradients are going to really mislead us into thinking we have a normal valve if, for instance, the valve area is not normal. So the date, type, and size of the valve is important because, again, when we're looking at echocardiograms to assess whether or not that valve is functioning normally, we will frequently not know what the baseline echo is. So these patients, if we follow them for long term, it is highly recommended to look at their baseline echocardiographic information in order to understand whether or not they've deteriorated. But sometimes they come in and we know what type and size valve they have, and so we have to use these tables, which are available. The guideline has these tables, but they're available widely, that allow us to look at the exact type and size and determine what the expected mean plus or minus standard deviation of that valve calculation. And many of the apps that are available also give you expected mean gradients. What we've learned is that we can also do that with the transcatheter valve. So this is a manuscript that just came out a few months ago of the expected valve areas by the transcatheter valves, which we are now all seeing more and more coming into our labs. And this is done again by valve type and size. And importantly allows us to, if we know the size of the valve that's gone in, to look and see whether or not they meet the expected mean plus or minus the standard deviation. And we'll talk a little bit more about transcatheter valves in just a minute. Now, the second thing that's important is the motion of the leaflets or occluders, and then to look and see whether or not you have calcification or abnormal motion, and then the valve sewing ring and integrity. And this gets to the determination of bioprosthetic valve dysfunction. This is again out of the European Society of Cardiology, looking at the definitions, and there may be 20 some odd papers out there proposing various criteria for structural valve deterioration, but most of them are fairly similar. And structural valve deterioration, again, is intrinsic to the valve itself, permanent changes of the prosthesis involving calcification, fibrosis, or leaflet tearing, versus non-structural, which is paravalvular regurgitation, for instance, or malpositioning, so in the setting of transcatheter valves now, malpositioning or late embolization. And then thrombus and endocarditis are their own specific entities. But one of the more important things that you can do is to understand the construction of the particular prosthesis that you're looking at. And this is just a summary of the various mechanical prostheses. This happens to be a single disc, a single tilting disc. It's an off-center tilt, and so to understand you'll have to ignore the little endocarditis on the mitral valve there, but on the aortic and the mitral, so you see that you have a single tilting disc, you have a major and a minor orifice that ends up creating different shears and also different velocities across each of the orifices. Obviously, you want to try and capture the major orifice, and then this is just an example of a bileaflet valve. This happens to be a St. Jude's, where you're looking in the mitral position, looking again for disc excursion. And so they should be almost parallel, but somewhere between 10 and 20 degrees from each other, depending on the type of valve. And then the closing angle, again, somewhere between 110 and 130, depending, again, on the type of bileaflet mechanical valve. And so these are the types of things that will allow you to judge whether or not these valves are normal. And then we know that in a number, almost in all of the mechanical valves, that washing jets are built into the valve construct to reduce the amount of pannus formation and thrombus formation on those valves. And so this is three-dimensional imaging of those, of the normal washing jets. And then specific to the bileaflet valve is the fact that they have a narrower central orifice and two large orifices on either side of that central orifice, which give you different velocities. And so the top spectral profile gives you the, a CW through the central orifice, where you can see a double envelope because the central orifice velocities are a little higher. It's a smaller valve area there. And then the two lateral and medial orifices give you what we would consider as the true continuous wave Doppler peak and mean gradients. So again, smaller central orifice, it's important to understand that you would not take that very faint high velocity from the middle orifice. And then obviously looking at the various disc motions, you understand that this was a bileaflet disc with one disc that's not moving. And the guidelines will go through how you determine whether or not you have pannus or thrombus. So much is involved with the history, which is again why understanding a patient's symptomatology and the duration of symptoms becomes so important. Thrombus is going to tend to be shorter duration. Pannus is going to be kind of a long, prolonged, gradual deterioration. In addition, pannus tends to form, this was pannus, and this was pannus that formed underneath the leaflet from the sewing ring. And so that's the most common, where pannus will come in from the sewing ring. Thrombus will tend to be on the other side. Now, what about biological prostheses? Well, there are a lot of different biological prostheses. This happens to be a pericardial valve. The pericardial valves tend to be a little bit lower in profile versus the porcine valves, which have to be the obligatory height of the sinus of a pig. And so the pericardial valves have larger leaflets, and they can the valve itself can be shorter. So these tend to be a little bit lower in height, and the leaflets will end up closing in the middle of the frame, versus this valve, which is a porcine valve. You can see the height, the profile is much higher. The leaflets should close just at the bottom of the stent. In this case, you can see prolapse of one of the leaflets, and then associated with that prolapse, severe central regurgitation. In addition, the bioprosthetic valves, you should look for the gradient, but in this particular patient, you can see that a mean gradient of 4 really underestimated what was going on, and this patient had an ejection fraction of 20%, and obviously severely low flow, which led to a mean gradient that was in a normal range, but obviously this patient has completely thrombosed their bioprosthetic valve. And then we want to look at the sewing ring. So this is a bioprosthetic valve with greater than 15 degrees of motion. 15 degrees would be considered normal, depending again on where your surgeon has implanted the valve. So if the valve is implanted closer to the left atrial wall, then the motion of a normal bioprosthesis or mechanical prosthesis may be a little bit excessive, but typically not more than 15 degrees. This is a dehisced bioprosthetic valve that is showing marked motion at the sewing ring. And three-dimensional echo and TEE obviously is integral to our understanding of what's going on with these patients. So you can see here a patient with a severe bioprosthetic dysfunction. You can see on 3D all the little suture the suture and knots on the surgical sewing ring, and then the two of the leaflets are immobile. This patient had severe prosthetic valve stenosis and ended up with a valve-in-valve procedure, which you can see here with a very good result. And so three-dimensional echo has really changed the way that we evaluate particularly mitral prostheses, since we don't have a lot of acoustic shadowing in our way. And this happens to be a patient that ended up with a paravalvular leak closure, where we can size precisely not only the regurgitation, but give the dimensions of the leak, which then allow us to choose our paravalvular leak closure device more accurately. Homographs and stentless valves present with a different problem. You don't see the echo dense, the echo bright sewing ring. Instead, you do see mild echogenicity of that sewing ring. This happens to be one of the first homographs that was ever placed in New York. One of my patients, and you can see that the sewing ring is now separated. I think there's a pointer here. is now separated from the valve itself is separated from the suture site, and in that setting you have a little bit of regurgitation, both paravalvular and then obviously a central regurgitant jet. This happens to be a 3F ATS valve. And again, if you know the construct of your valve, it'll tell you a lot. This valve is perfectly normally functioning, but we end up seeing the suture line here of the valve, which obviously has to be sewn all along. This is a valve that requires a lot of surgical skill, but the suture line will come, and this is just third dimension imaging of that suture line around the sinuses that are normal, and you can see again the coaptation points of the leaflets in this stentless valve. So what about the Doppler evaluation? The contour of the jet is important, peak velocity and gradient, but as you already saw with the mitral prosthesis, the velocity and gradient do not tell you, do not take into account the flow across the valve, or low flow states or even high flow states. So they can really, you can misjudge the prosthesis function if you only look at velocity and gradient. And so we're looking also at other measures of valve area, such as Doppler velocity index, effective orifice area, and then we'll talk about regurgitation at the very end of this talk. So when you're looking at mechanical valve function, they're fairly well defined and based a lot on the criteria that we use for native valves. But peak velocities of over 4, mean gradients of greater than 35 or 40, Doppler velocity index of less than 0.25. Those indicate severe or suggest severe stenosis with an indexed and the contour of the jet velocity obviously will also tell you. So a more rounded, symmetrical contour tends to be consistent with, again, parvus and tardus on your carotid palpation. And so those are rounded, symmetrically contoured jets. And then the acceleration time. Now, acceleration time, if you're going to use it, needs to be done in the setting of a normal heart rate. And so the cutoff for an abnormal acceleration time, so again, delay in the peak, is greater than 100 milliseconds. But obviously, in the setting of tachycardia, you may want to correct that for the heart rate, and that's by dividing by ejection time. And so an ATET index of greater than 0.4 is also consistent with prosthetic valve obstruction. Some people use 0.37. As their cutoff, because it's relatively independent of the Doppler angle, although we would always advocate for you to try to be on axis. But you all know that the pitfalls of velocity and gradients are significant, that you can underestimate the gradients if you fail to align the beam, if you have a low flow state or elevated systemic blood pressure. It will also reduce the gradient, and you can overestimate the gradient in high flow states if you mistake MR for the transaortic flow, if you attempt this angle correction, which we would ask you not to do. And then a phenomenon called pressure recovery, which we'll discuss in a second. So to get around the flow state, to normalize for flow, we use the continuity equation, which I don't probably need to tell this crowd what that involves, but obviously both the guidelines state that the EOA by continuity is a better index of valve function than gradient alone, and in the European guidelines, prosthetic EOA is less flow dependent than transprosthetic velocity or gradient, thus often a better index of intrinsic valve hemodynamic performance. And so you know that we calculate, we like to use VTI. You can use the peak velocity. This is an instance where we're using velocity time integral so that what's on the numerator is stroke volume. So area times the VTI, which is the stroke distance. So it's area times distance is volume. And so what's on the top here is all stroke volume. And then divided by the VTI across the aortic valve gives you your unknown, which is your valve area. In the setting of not knowing what the diameter is or being uncertain, and remember, in the setting of a prosthetic valve, whether it's a transcatheter valve or a surgical valve, the accepted way of measuring the outflow tract is on the outer edge of the sewing ring to the outer edge of the sewing ring. And so it's all below the valve, outer to outer, and that's what's considered the standard procedure for assessing the LV outflow tract diameter, and that's true for the the transcatheter valves as well. Outer to outer is your diameter you use in the formula, and then your velocity sample volume for your PW should be just ventricular to the stent itself. So you want to be slightly in the ventricle. And then if you don't agree with your own, if you're unsure about your diameter, then just look at the Doppler velocity index. This happens to be the modified index because we use the velocity time integral. But you could also use velocity. And typically a prosthetic valve, which is intrinsically a little stenotic, will typically be above 0.3 to 0.35, and most of the DVIs reported for prosthetic valves are closer to 0.4 and 0.5. And that is also true for the transcatheter valves. Now, GOA versus EOA, there's two different terms of geometric orifice. There's the ones that are given to you by the industry, where they are measuring the outside of the prosthesis. And then there's the GOA, which is another definition in the guidelines, is the internal valve area theoretically available for the bloodstream to pass through. So that's actually the internal diameter, and assuming that the leaflets are fully opened and that is going to be available for flow, which obviously is not true since you have leaflets, and the leaflet construct may reduce the amount of area passing across the leaflets. The EOA corresponds to the smallest area of the jet passing through the prosthesis as it exits the valve leaflets, and that is measurement of the vena contracta orifice area. And then both the shape and the inlet and the size of the orifice affect the ratio of GOA and EOA. So they're not always quite the same relationship, and it depends again on the construct of the valve. Now, the other thing that influences gradients is going to be pressure recovery. This is in this beautiful illustration, they use a bileaflet valve. It turns out it's probably not pressure recovery that accounts for some of the high gradients across the central orifice, but it's a good example. And what happens is that when kinetic energy is lost as it crosses the valve, it has to be recovered because you have conservation of mass and energy, and so it has to be recovered in pressure because you don't see high velocities all the way down to your toes. And so that kinetic energy is then recovered as pressure and is called pressure recovery. Now, the higher the turbulence of the flow, the more energy can be lost in heat, as well as other things, and the continuity and the Bernoulli equation starts to fail, but you end up with more with less pressure recovery. So in valves that have more turbulence and therefore dissipation of the energy with heat, you may actually see less pressure recovery. But in a lot of the valves, you're going to see pressure recovery, and that's why you will get a discordance between the vena contracta area and what the pressure gradient is measured by cath. And you just have to remember that this is possible. It becomes more of an issue with the more funnel-shaped the outflow. So if you have moderate AS with a small aortic root, a lot of pressure recovery. More funnel-shaped, the worse. When you have severe aortic stenosis and then a big aorta, less pressure recovery. So the definition of structural valve deterioration by Capodanno, and again, this is from the European Society of Echo, uses just gradient and says that if you have a change in gradient of 10 to 20, then a mean gradient, then that's going to be abnormal from baseline. And certainly if you've got it an absolute mean gradient of 20 to 40 millimeters of mercury, that can't be normal. And then if you have more than 1 plus regurgitation, that's also not normal. And then they give criteria for severe. And then there's also the morphologic side where you're looking at the actual leaflet itself to determine structural structural valve deterioration. But in the manuscript that I mentioned before, this was just published about three or 4 months ago. Neil's on that manuscript as well. We looked when we looked at the mean plus or minus standard deviation of the effective orifice areas of the transcatheter valve, it turns out that the standard deviation for both valves, even though the valve areas were very different and the mean gradients were also different, that the standard deviation from the mean was very consistent between the valves, as it is when you look at the surgical valves as well. And it's about a 20% plus minus 20% for one standard deviation of the DVI and 25% for the EOA. And therefore, possible structural valve deterioration, we would like to add a measure of valve area, so EOA or DVI, to the current definition of structural valve deterioration. And indeed, this is what VARC 3 will do when it's published later this year. And so an EOA of one standard deviation above what is accepted, again, this is assuming that you don't above the baseline, and then greater than 20% of the DVI above the baseline is considered abnormal. And what's considered severe and relevant and probably clinically relevant is if you're 2 standard deviations above what would be considered the mean. So an EOA of greater than 50% in decrease and a greater than 40% decrease in the DVI with a gradient of greater than 20, change in gradient of greater than 20 millimeters of mercury. And all of these must, of course, be associated with morphologic changes similar to what the European guidelines have suggested. So we would hope that this will be added to the criteria for structural valve deterioration. Now, if we move on to prosthetic regurgitation, and I'm not going to spend a lot of time here, we look at similar variables and parameters as we do for the native valve. So we'll look for the for the vena contractus and measure the vena contracta and then compare that to the diameter. We never, for aortic regurgitation, either for native or for prosthetic regurgitation, we never use jet length or jet area. Those were very old papers from 1985. Using those criteria, we have not, for many guidelines now, advocated the use of jet length or jet area for aortic regurgitation severity assessment. And that has to do, again, with the hemodynamics of the valve, with the pressure gradient between the aorta and the LV. We do look at the jet density. We look at the jet deceleration time. Obviously, all of these things are going to depend on how well you can align your insonation beam with the jet, and therefore you don't want to rely on it if the jet is going out of plane. And in addition, the pressure half time is highly dependent upon the compliance of the aorta and the LV, such that in older patients that have poor compliance of the aorta or poor compliance of the LV, that slope will be very rapid in the setting of mild aortic regurgitation. So a caveat there in our older patient population. And then another criteria that we have been using is just to look at the stroke volume. I mean, we would measure area, but if you just want to look at the relative stroke volumes between the LV and the pulmonic in order to assess regurgitant volume, then the difference between the two would be quite significant, greater than 60 cc's typically, for severe regurgitation. Now, you can look again at diastolic flow reversal. Holodiastolic is what is required if you want to call it severe. We don't use just early diastolic. And in the European guidelines, they use a cutoff of the velocity has to be greater than 0.2 centimeters per meter squared, and that makes sense to me in order to reduce overcalling severe regurgitation. In addition, we like to quantify, and you can semi-quantify using just the vena contracta width, or you can quantify using regurgitant volume, regurgitant fraction, and effective regurgitant orifice area. Remember for aortic regurg that the severe cutoff for effective regurgitant orifice area is 0.3 centimeters squared, not 0.4 like it is for mitral, and that has to do with the diastolic filling period being longer. So again, regurgitant volume is the same at 60 cc's, but because the diastolic filling period is longer, the hole can be smaller, and it will still represent severe. So 30 millimeters squared for the EROA, 60 cc's for regurgitant volume. Now, for mitral valve, similar things that we'll look at. Obviously, even more important to look at heart rate here, since the diastolic filling period, systolic filling period will tend to remain the same. Diastolic filling period is very sensitive to heart rate, so you must report this in terms of heart rate. And then these are some of the cutoffs, which now I'm running behind, so I'm going to close off pretty soon. But remember, we do not recommend using pressure half-time, do not recommend using pressure half-time for prosthetic valve. Instead, we would like to use, if possible, and that assumes that you don't have a lot of regurgitation of the non-stenotic valve, use the continuity equation. And so this is, again, LVOT stroke volume divided by the mitral continuity equation, and you can use pulmonic as well. And remember that in the guidelines, they now reverse the DVI. So instead of doing what should have been LVOT VTI to mitral valve VTI, it's now, and this is just in all the guidelines, it's now mitral VTI divided by LVOT VTI, and so now what's normal is less than 2.2. Sorry, I wish we hadn't done that, but we did. So again, prosthetic regurg is a problem for us in the setting of acoustic shadowing. This is where TEE may be extraordinarily beneficial, particularly for mitral, but also for posterior aortic jets. And in addition, one has to remember that there are a lot of different etiologies of hemolysis. Some of these patients present with a variety of different types of regurgitation and hemolytic anemia. So both hemolysis and heart failure are the main etiologies to go after a paravalvular leak. All of these criteria obviously come with some reduced sensitivity or specificity. I'm again going to just run through these are very standard measures. And then we obviously have both semi-quantitative and quantitative parameters. Again, 0.4 now being the cutoff for EROA in the setting of the same regurgitant volume of 60. And all of these cutoffs are available. Prosthesis patient mismatch, a big issue. The guidelines tell you the cutoffs for both mitral and aortic prostheses. So greater than 1.2 is normal for mitral, greater than 0.85 for aortic. Again, in the transcatheter aortic valve paper, we've actually given you the expected valve areas for the annular size. So unlike a surgical valve where you just expand the annulus to fit the surgical sewing ring, we can't do that in the transcatheter valves. So we've given you expected valve areas for whatever the annular type of measurement. So area for the sapien valve and the perimeter derived mean diameter for the core valve, and allowed you then to estimate what the valve areas would be for each of your patients, allowing you then to determine whether or not you'll have prosthesis patient mismatch and avoid that. And then to close, just remember that we always look at all of the other parameters associated with our dysfunctional valve, and that includes right and left ventricular size and function, left and right atrial size, and concomitant valvular disease with an estimate of pulmonary artery pressure. And above all, it's really, really important, if possible, to compare all of your parameters with a baseline echo. We strongly recommend a baseline echo within 30 days of initial implantation, whether it be surgical or transcatheter. Thanks for your attention.